Hello, good afternoon. This is Gary Swan. Thank you for joining us on this webinar. Today we're going to be going over APM4, the quality improvement components of the model, and addressing any questions that you have. It looks as though we have a couple of questions. I'll just confirm for those that are responding on our questions panel, if you're able to hear me, please let us know. If you're not able to hear us, please send a note and we'll sort that out. For this webinar, we'll submit questions through the question and answer panel. We'll get to your questions at the end of the webinar once we go through the materials. Again, this webinar will be recorded so that you can review it at a later date. So in the room, I am Gary Swan. I'm the lead on this work within the policy division here at the Healthcare Authority. I also have
Michaela Snook, FQHC RHC Unit in Finance.
And Patrick Miles, FQHC RHC Unit in Finance.
So before we get going, I'd like to just provide a quick overview of APM4 for those staff transitions that may be happening at the provider level, just so that everybody understands the model that we're operating under. This slide here is really just a quick overview or background of APM history in Washington State. We are on the fourth iteration of an APM here in Washington. This is the first value-based payment methodology that's been implemented. The first payment methodology in APM1 essentially takes 99 and 2000 costs and inflates it by a Washington State inflation factor. The legislature came back in 2011 and sent everybody back to their respective payment for a period of time plus 5%. And then in July in 2011, we used the same APM, so average cost of 99 and 2000, but inflated by the Medicare economic index. Really providing that slide just as a background, we generate a payment here in Washington State, recognizing that our FQHCs generally receive higher than regular Medicaid fee schedules, and by virtue of their designation, get an extra, essentially an extra payment. So this slide goes through the flow of payments that exist under the encounter-based system. FQHCs contract with managed care organizations, and those relationships exist in various forms, either the fee-for-service or other kinds of value-based capitated or value-based payment arrangements. We receive rosters from managed care organizations. We use those rosters to generate what are called enhancement payments. Those enhancement payments are paid out on a monthly basis to our managed care organizations. The managed care organizations pass those dollars through to FQHCs and RHCs. At the end of the year, we perform a reconciliation where we true up those dollars that are received from managed care organization with the enhancement payments to the true encounter rate. I show this slide both as history, also to show we are not changing under this payment methodology the flow of dollars. We still generate an enhancement payment based off of rosters that are reported from managed care organizations to HCA and do a reconciliation at the end of the year. Under APM4, clinics or participants receive no less than their encounter-based rate. So you still, at a minimum, receive your APM3. Providers retain that right to opt out of an APM4, so you can drop out upon notifying HCA. Again, the flow of dollars, those payment relationships aren't changed under this payment methodology. We sought to line up with our managed care organizations and use the same reported rosters, assignment files as a source of generating enhancement payments, and also use them as the source to generate your cohorts for your performance scores. So those are the same populations, both for payment and for your performance. And then we prospectively adjust the APM4 based off of participants' quality performance. This slide just goes over the conversions of an encounter-based rate to an APM4 per member per month amount. So we take the APM3 encounter-based rate. We used 2015 as the baseline year for conversion. So we take the rate from 2015, multiply it by the number of encounters, which would have given you your APM3 total payment. And then we take those reported rosters or those member months from managed care organizations and divide that total amount by those member months. And that will give you to a per member per month rate. So instead of receiving an estimated $200 rate for your encounter base, you now receive maybe a $60 PMPM rate. We carry all rates forward in future years and trend them by the Medicare Economic Index. For APM4, as we're moving toward value-based, so moving toward expanded team-based care and management of the patient populations, we link that PMPM rate to quality performance in future years. This is really just a visual representation of the previous slide. So historically, under an encounter-based system, you would have a certain number of billable encounters, and we reconcile to those total billable encounters. Under APM4, we've set a essentially capped rate going forward in future years. And as the visit rate changes or the number of billable encounters changes, we still hold participants true to the overall PMPM. So you're able to replace some of those billable encounters with quote-unquote non-billable encounters, so alternative types of access or visits to your clinic. And by virtue of receiving this PMPM, we tie it to quality performance and adjust it in future years based off of that performance. If participants are able to meet the goals or targets on the performance expectations, they will receive the full PMPM in future years. If they're not able to perform on the measures, then will be prospectively adjusted down in future years, but no less than APM3 or your encounter-based rate. So essentially, your encounter-based rate will always remain as a floor within this model. If you're unable to perform on measures in 1 year, but you're able to recognize what the issue is and engage that patient population or implement the new programs that turn those measures around, clinics are able to earn back the full benefit of their conversion PMPM as trended by the Medicare Economic Index. So you can earn back those dollars in a future year. And again, this is a short visual representation of that process. So those non-billable encounters, to receive the full APM4 PMPM, we've tied the attainment to now 6 quality improvement measures as we dropped the asthma measure in the previous year. So you are expected to perform on 6 quality improvement measures to receive that full PMPM in future years. The quality improvement model, or how participants are measured under an APM4, rewarded both for attainment and improvement. So these are set on an individual basis for each participant having their own baseline and performing against their own quality scores year over year. But we dynamically weight against NCQA 90th percentile target and the means of those measures, and then roll them up as a composite score. Each participant within this model is rewarded both, again, for their attainment and improvement factors. So if you're not able to hit the 90th percentile, that's okay, as long as you're able to move on the improvement of the measures. So those that are low performers are able to win out under this model, as long as they're able to continually improve year over year until eventually we hit the ultimate targets that are set within the model. So again, clinics are compared against their own baseline. So in this case, for our current reporting period, we're comparing 2017 to 2018. We're again using those MCO reported rosters, or those member months, as essentially the source of truth. That's where we generate the patient population. And again, rewarded for the improvement and attainment rolled up into an overall composite score, which is your quality improvement score. We'll use the quality improvement score, which essentially gets converted to a percentage and then applied to your PMPM in a future year. So we have a tool for the quality improvement model. You can use this tool to gauge what your performance is at and where you might want to focus your efforts in your performance year. We recommend that our providers utilize this tool as a gauge to estimate what measures they might be able to move and by what percentage they need to move them to hit their scores. This is the same model that's been implemented in our contracts with participants and is the same as the previous tool, but we've just updated the tool for operational purposes. So if you don't have the most up-to-date tool, we can make sure and send that back out to you. Just let me know. So there's a question on assignment. We'll get to that in the upcoming slides. So this is a timeline just to recognize what performance will impact what years. So right now we're comparing 2017 to 2018. We're in the 2018 reconciliation reporting period in 2019. We will use those, calculate those scores, complete financial reconciliation during this year, and then apply that rate to the PMPM for implementation in 2020. So this performance, prior year performance, 2018, will impact 2020. If you have questions on financial reconciliation, please reach out to HCA, FQHC, RHC questions. And again, reminder for those financial folks on the line that reconciliation under this model is due September 30th, 2019. Then just as an operational note, in terms of transfer of the data, I appreciate everybody's time and responsiveness getting back to us on making sure that your keys, PGP keys, are up to date and that we have updated contacts for FQHCs participating. When we generate the data, we need to make sure that it's securely transferred. So we encrypt the data using that secure key, upload it to a WATEX server for FQHC retrieval and decryption. Again, when sending those data back to HCA at the end of the reporting period, please don't forget to encrypt your data prior to transfer. If you have any questions on the encryption process or on establishing your key, please feel free to reach out. We can make sure that you're up to date and up to speed. So I'm going to transition into the current performance reporting period and go through some of the reminders for this process. So this is a slide that, for those that have been around, may remember. We presented this a while ago now, last year prior, on the reporting process. Essentially, when we launched APM4, recognizing that we launched mid-year, so we launched in July of 2017, and recognizing that performance was only for 6 months, we agreed to account only for those clients that were had essentially impaneled at our FQHCs, or clients that you actively manage. So we essentially dropped all of those clients that were assigned but did not have either one being engaged by the SQHC, was improperly assigned to the SQHC. We dropped all of those in the performance scores for 2016, 2017. And so that's how your QIS was established. Going forward in future years, we noted at the time that we would be moving towards trying to get as close as we can to the MCO reported rosters as being the ultimate source of truth. So making sure that the entire assigned client population is being accounted for in measured performance. So recognizing that, a couple of things will happen. We'll be resetting the 2017 baseline for those measures that we can get to that total population of the MCO reported assignments. And then looking to our SQHCs again to reconcile and report back data to HCA. So this slide here goes over the measures that are included in our QIS and who is reporting which measures. And important to note here that we dropped the asthma measure, recognizing that it was too small of a sample size really across the board to effectively implement. So we've effectively dropped that measure. So for the diabetes measures and controlling high blood pressure, SQHCs self-report these measures. HCA generates a provisional cohort based off of continuous assignment and continuous enrollment. But it requires that clinical data that SQHCs have to report back the numerator and the denominator. For childhood immunization status, HCA can get to the denominator, so at least we can get to the total patient population that SQHCs are expected to perform on. But we'll be looking to our SQHCs to report back the performance for the numerator on Combo 10. For antidepressant medication management and well child visits, those are fully generated based off of administrative data, and we're able to get to the full population both for the numerator and the denominator. So this round of reporting, we've sent this data out, but do not need to reconcile the antidepressant medication management and well child visits. But if you have specific issues with the data, please let us know, and we can follow up appropriately. So for the timetable, as everybody knows, we were 2 days late in getting out the data. I've updated the delivery date for participants offset 2 days. Again, calling out the activity for these timeframes. So HCA has generated the data and sent it out to participants to review and reconcile and report back to HCA due on October 2nd. We will then take that data, finalize rates, and report back final rates at least by November 30th of 2019. Apologies for missing that. So I'm going to go through some question and answers, frequently asked questions, in particular for those that are new to this process. So this, as I mentioned before, this data represents Medicaid managed care clients only. They're generated from those reported rosters of those assignment files by managed care organizations. We filter those based off of continuous assignment and continuous enrollment. So 11 of 12 months. That means that even if there was a break, there could only be a break of no more than 1 month for them to qualify for your measure. We apply HEDIS specifications per 2019 HEDIS specifications to each measure to generate the populations. And for those measures that we can't generate the numerator and the denominator, we generate provisional cohorts. So, for example, diagnosis of diabetes, we can see that in the administrative data. We generate a patient population as at least the broader set of the potential clients that could fall into that that patient population. The date range of the data. So the prior performance year is 2017. We'll be using that as the baseline to compare against 2018. The performance year is 2018. And we'll establish scores based off of the composite score of performance from 2017 to 2018. If you have questions for your calendar 2017 data, we have finalized those data. If you have something specific, please reach out. But largely those are finalized, and we're not going to be updating them. We will be looking to the scores that you got for diabetes care, for control and blood pressure control, and then controlling high blood pressure. We'll not be adjusting those measures as we can't get to anything more specific based off of solely clinical data. The other measures we will be resetting based off of the existing data that you sent to us. So the administrative measures will do a reset on, and it'll essentially be the first round of data that we sent you back in July of 2017 or August 2017 will be what your scores essentially will be. And again, if you have any questions, please reach out. So for the measure specifications, we're using 2019 HEDIS measure specifications. We are using the same, per our contract, we're using the same target. So the 90th percentile is, I think, based off of 2014 NCQA HEDIS for managed care, HMO. But the HEDIS specifications for the measures, how we've generated the cohorts and the populations or your rates, we're using 2019 specifications. We can't provide the specifics, the details of the coding and things like that. For that, you have to reach out to NCQA to get the specs, but we can provide some technical assistance if it's necessary or if it's important for addressing any questions that you might have. And there was also some general guidance provided in the spreadsheet. So questions on use of the spreadsheet. This is the same process that you performed in 2018 on 2017 data. Essentially going through the spreadsheet, we provided the provisional cohort for those diabetes and hypertension, and to go through those populations and reconcile them back with the clinical chart information. Essentially, if they perform to care was delivered according to HEDIS specifications, provide a 1 in that column. If they do not, or you didn't perform, place a 0 in the column. So for the measures that FQHCs are to reconcile and report back, participants are to report back to HCA, the numerator and denominator for both the diabetes care, poor control and blood pressure control, and then controlling high blood pressure. Again, we provided a provisional cohort there, but we look to participating FQHCs to go through and tell us essentially those clients that you have data for that are impaneled within your clinic, performance on those measures. And then reporting back on the numerator for childhood immunization status combo 10. HCA has again provided that provisional cohort. We've provided the total potential patient population or the denominator for our childhood immunization status, combo 10. And we reported the numerator and denominator for antidepressant medication management, acute and continuous phase, and then well child visits. So we've gotten the question before that there's many patients listed show no evidence of having a measured diagnosis or appear to qualify for the measure. Again, really, if you can't get their performance or their score, if they've met the HEDIS specifications on this, report them back as a 0 in the denominator, so you're able to essentially remove them from the patient population. If they are your client and you're able to see that they fall into the denominator, report back the performance on the numerator. And that's for those self-reported measures that we've been going over. For the combo 10, just reporting, again, the numerator. Another version that we've essentially gotten on these reporting, when the client, you don't believe that the client is your patient, but you may have some data on them. For the measures for diabetes care, program control and blood pressure control and controlling high blood pressure, you're able to throw those out of your denominator. So we're essentially looking at those in panel clients for those measures. And again, for the childhood immunization status and for antidepressant and well child, where HCA was reporting the full denominator on those measures. We've had a technical question before on poor control, asking that you please make sure to report as the measure is specified, report actual poor control and not invert the measure. HCA will invert the measure when calculating your performance on your quality improvement scores. If you're using the tool and putting this measure into the tool, then yes, you do need to invert the measure when utilizing the tool. So those are a high-level overview of the reporting process and the steps to reconcile. Again, we're happy to provide some technical assistance if it's helpful for participants. Please just let us know and we can set something up. It looks like we had a couple of questions on reporting, but I think we addressed those questions. If there are additional questions, please feel free to input them now or reach out to us after the webinar. I'll give us a few minutes if there are any additional questions on the panel.
I don't know that one. That because no one responded.
Oh.
Saying that this was addressed.
They should include professionally. So we had a question early on. Why is the source of truth?
Oh yeah, sorry, it's right here. But yeah. All right.
So why is the source of truth based on NCO reported member months and not HCA assignments? So again, previously we looked essentially to those clients that you had data on as essentially the source of truth, and because we did it on one set of measures and recognizing that we launched mid-year, we looked to that across all the measures. But going forward, we're looking for the source of truth as being the entire patient population as far as we can get it. So still looking to those in-panel clients for the SQHC for the clinical measures, and then for the administrative measures, the measures that we can get to the denominator on, we've expanded that. I believe I sent out the slides just as the webinar was going. I'll make sure that those got out to everybody after the webinar. So for there's a question on Please provide more clarification regarding HCA reported denominator and numerator for patients we don't believe are ours. So for those measures that you're fully self-reporting on, the comprehensive diabetes care, poor control and blood pressure control, as well as controlling high blood pressure, those you can put a denominator if you don't believe the client is yours or you don't have information to report back. You can report a 0 as the denominator for those measures. For all other measures, HCA has set the denominator essentially based off of the client assignments per our kind of previous presentations and announcements on this work. So you should be receiving on a monthly basis from the finance side regular assignment files, and that shows the entire patient population. We've also sought to try and get a provisional cohort or an early look at performance for the current calendar year. We sent that out earlier in 2019. And that shows the total potential patient population for those that could fall into 2019, and people could fall off but not be added into that potential patient population. So you should be able to identify who those clients are and be able to do engagement and manage those clients into your clinic or get them reassigned. So I have a question. Have you looked at the validation of data and how will we send info to validate our data versus yours? So our data is based off of again, the total patient population, the reported rosters from managed care. The only data that I think that we'll be looking to validate again goes back to those self-reported measures. So poor control, blood pressure control, and controlling high blood pressure measures. And again, reporting back the numerator denominator for those measures. If there are specific questions, we've attempted to try and take those offline on the technical assistance approach, recognizing data security challenges that we've encountered in trying to transfer back client identifiable information outside of this process. So if you have specific questions on our data, or if there's something that needs to be addressed, please reach out to work with us directly. So there's a question there saying that some of the data comes from claims, but sometimes there's a difference within the EMR. Again, we're looking to the Medicaid managed care rosters as a source of truth, so that those reported data back to by virtue of claims or administrative data, essentially a source of truth for those administrative measures. So managing your client assignments or managing those rosters to your organization, and then managing back on making sure that you are reporting those data through claims is how we will be measuring performance for these measures. Okay, we'll give folks just a minute more, and then we'll call it a day. Okay, if you have any other additional questions or have other follow-up, please feel free to reach out directly, either to myself or reach out to SQH CRHC questions, and we'll get you answers as soon as possible. Thank you very much for your time.